Hi, my name is Kathleen Lee. I work at Beth Israel Deaconess Medical Center, and today I'm going to talk to you about comfort, symptom management for patients at the end of life. I have no disclosures today. And our learning objectives today is firstly, describe common symptoms experienced by the imminently dying patient in their last hours to days. Secondly, understand the clinical evidence for interventions for symptoms at the end of life. And then lastly, describing educational needs of families, loved ones, and caregivers. Now, why is this important? So most people have not witnessed people dying. And so there's false expectations regarding the dying process. What we can do as providers is really help patients and families prepare for the final hours of their lives. And the stakes are quite high. These are often moments where patients' family members will remember. And so patient suffering versus comfort is quite important. And sometimes it can mean the difference between prolonged family distress lingering after the experience versus health and bereavement. Now, here are some common symptom signs and issues that come up at the end of life for people. Symptoms are commonly like pain, shortness of breath, respiratory secretions, weakness and fatigue, and sometimes even delirium, confusion, and agitation. We often see signs of decreased perfusion and circulation, diminished oral intake. And then we'll also review specific issues that come up at the end of life, specifically the role of artificial hydration and nutrition, as well as palliative sedation. Now, when it comes to symptom management at the end of life, a thorough assessment is crucial. Palliative care as a field is still early in our practice, and our evidence base is not well developed and is still sort of building. And so practice-based is really focused on existing evidence and expert consensus guidelines. When it comes to decision-making at the end of life, for example, choosing to tolerate a little bit more pain and alertness rather than being a little more sleepy and sedated on opioids, it's really important to take into consideration patients' values and preferences, as well as clinical and ethical considerations on a case-by-case basis. And as many of you already are familiar, doing a very thorough pain assessment is critical. Thinking about the sources of pain. Is it part of disease progression? Is it bed sores because people are more immobile at this time of life? Or people have considerable edema and swelling in their body, causing aching? Do they have arthritis? Are you seeing objective signs of pain, whether it's moaning or grimacing, eyebrow furrowing, or guarding? Sometimes it can be quite challenging to distinguish from other distress in the nonverbal patient. So you often using, things like the Wong-Baker Faces pain rating scale. And sort of thinking about takeaways that is just pretty bread and butter. You adjust the opioids for patients no longer able to swallow, and thinking about the opioid equal analgesic table. Thinking about fentanyl patches for patients that are unable to swallow. Oftentimes using sublingual conversions underneath the tongue can also be a formulation to think about. When it comes to dyspnea, shortness of breath, or labored breathing, opioids are often our first line of treatment. We tend to think that this decreases the central perception of air hunger. It is quite a subjective sensation. Opioids are quite safe and effective if you're using your calculations in terms of dosing in a safe way and doing your math. There's no deleterious effects on ABGs or O2 sats, and there's no significant respiratory depression and effect on ventilator parameters. We often will use benzodiazepines as second line, particularly if they're associated with anxiety. Though, again, you need to carefully weigh the risks sort of associated with benzodiazepine-related altered mental status. Other things that come to mind when you're thinking about dyspnea management at this time of life: supplemental oxygen. Data shows that it is only beneficial if hypoxemia exists. And then there's a thought, do we even measure in these cases O2 sat? There are also data showing that air fan really just stimulating sort of your nasal receptors, baroreceptors in that area, shows effective dyspnea relief. And then other interventions depend on the etiology of the dyspnea. Steroids, bronchodilators, diuretics. Does someone have a malignant pleural effusion that can benefit from a therapeutic thoracentesis? So really sort of thinking about what that underlying etiology is key. And then there's also expected end-of-life breathing changes, as your respiratory centers in your brain are just becoming more depressed. You often will see shallow with apneic periods in people's breathing. You'd see changed stogies related to a significant neurological change. And then a takeaway that's important to keep in mind that sometimes tachypnea is just a respiratory compensatory measure, right? If people have metabolic sort of derangements. And so sometimes tachypnea in and of itself is not necessarily a sign of discomfort. So something to keep in mind. So opioids for pain or dyspnea, do we use boluses or continuous infusions? And sort of safe best practices for opioid use at the end of life is really just trying to initially use bolus doses as needed for current symptoms, right? It's those acute PRN boluses that are really going to help in the acute setting. You're really using the continuous opioid infusion as a long-acting medication because that's going to take quite a long time, as you see in that graph, to reach a steady state, even 6 to 8 hours at times. So you really want to titrate the rate based on sort of the bolus doses calculations that you're needing to get adequate symptom relief. So respiratory secretions is also quite common. The ability to swallow and your cough gag reflex diminishes and become weaker over time. And so your saliva pools in the posterior oropharynx and the upper airway. So you get what we commonly call gurgling, noisy breathing, rattling. Sometimes you've heard it called the death rattle at the end of life. This happens to 1/4 to half of dying patients. And often it's more distressing for family members and providers than for actual patients. Treatments we use can be non-pharmacological, repositioning. We often will say to avoid suction because that can cause more distress by doing deep suctioning on patients. Pharmacologically, we use anticholinergics like glycopyrrolate, scopolamine, atropine. But interestingly, a Cochrane review, which still stands from 2008, showed that there's no evidence showing that either treatments, either non-pharmacologic or pharmacologic, are better than placebo. So something to keep in mind. Weakness and fatigue, loss of mobility, more time in bed is quite common. We have increased risk of pressure ulcers, edema of the extremities, joint pain, stiffness, and movement can become more difficult, particularly even repositioning. And so we often will, for best practices, pre-medicate with opioids and pain medications during this time before any movement. Delirium also is very common. And there's many presentations, so there's quite a spectrum. There's restlessness and agitation, confusion, picking at blankets, and sometimes this can mimic pain, like moaning and grimacing, and it's hard to sort of distinguish between the two. Delirium can be reversible up to 50% of the time, even in the final days. So things like infection, medications, constipation, urinary retention, metabolic derangements, or even undertreated pain are really important to consider when you're thinking about why people are presenting with delirium, because a lot of times you can treat it. And then there's thoughts, does it need to be treated? So it's important to distinguish between distressing and harmful, potentially delirium, versus at times comforting auditory and visual hallucinations during the end of life. And so a lot of times family education and reassurance is quite important. and kind of getting a sense from patients if they're still lucid, whether or not they are comforted or they're very distressed by what is going on with their confusion or hallucinations. In terms of non-pharmacological treatments, family presence is key, reorienting frequently, trying to preserve their sleep-wake cycles, opening up curtain shades to make sure that they have sunlight during the daytime. Minimizing restraints and reducing stimulation is key as well. And thinking about pharmacologic treatments of delirium, first line, we do use antipsychotics, anti-dopaminergic agents like haloperidol and chlorpromazine, which can be more sedating, as well as second generation antipsychotics like olanzapine and quetiapine, which has less EPS risk. There is some data over the past handful of years that benzodiazepines, along with antipsychotics, can be effective in the pharmacologic treatment of delirium. There was an RCT study out of MD Anderson that showed that it was quite effective along with haloperidol with advanced cancer patients with agitated delirium. But then again, with the caveat that this can sometimes worsen confusion in patients as well. And so it's really thinking about the right patient, the right scenario, clinically thinking about benzos. And then another thing you can think of is opioid rotation if you are considering neurotoxicity as a cause for the delirium. Another sign we commonly see at the end of life is decreased circulation and renal function. So you see decreased peripheral perfusion, dehydration, decreased cardiac output, cyanotic extremities, blue, purplish modeling, cool to touch. Sometimes you see tachycardia and hypotension, as well as renal failure and decreased urine output, whether it's oliguria, anuria, or uremia. There's also a role for complementary therapy at the end of life. Acupuncture, Reiki, music therapy, and art therapy. There's quite an evidence base for acupuncture to really help with pain and nausea, for adequate symptom relief. And Reiki, music, and art therapy can really help cultivate more calm, enhance quality of life in patients at the end of their lives. We commonly also will see incontinence as a sign, urine and stool due to bedbound status, and immobility, sphincter control is lost. Family education about cleaning and changing is key. And you really want to consider risk and benefits of urinary catheters or fecal management systems during this time too for comfort. Decreased food and fluid intake is quite common. Loss of appetite and dehydration are nearly universal prior to death. It's very common where concern for starvation can be a source of familial distress. And oftentimes, just really, again, as we talked about, really important to educate people that a lot of times we think that sort of dehydration and sort of loss of appetite is not causing suffering. It's part of the dying process. And people aren't starving. It's really sort of their disease process that is driving their dying process, not the starvation itself. The role of IV fluids at the end of life. So early literature showed that dehydration caused delirium, could worsen constipation, risk of bed sores, cause renal failure, myoclonus, nausea and seizure. And, and some argue we don't have proof that dehydration doesn't cause discomfort. There are, though, a small handful of studies that show the majority of patients, as we were talking about just a couple slides earlier, never experience hunger or thirst. And complaints of thirst and dry mouth are actually even more alleviated rather than IV fluids being hooked up to a patient with good oral mouth care and sips of liquid straight to sort of your oral mucous membranes. And there are also studies showing that symptoms of thirst and dry mouth are not really correlated to level of biochemical hydration. Other research in terms of artificial hydration and its role at the end of life, it actually alleviates membrane dehydration signs, but actually can worsen peripheral edema, ascites if people have ascites, and pleural effusions. Artificial hydration doesn't improve hyperactive delirium, communication capacity, agitation, myoclonus, and bed sores. And there was an RCT that showed that it does not improve dehydration symptoms or survival, and no significant benefit in palliative care patients, but not enough high quality studies to inform practice recommendations. And so when patients and families are requesting artificial nutrition and hydration, as we talked about, it's really sharing that the lack of appetite is nearly universal. It's quite common during this time and place of life. Thirst and dry mouth can be alleviated with mouth care, oral swabs that often families can do for their loved ones. And artificial nutrition hydration does not help with fatigue or delirium and can worsen fluid retention symptoms. And so sometimes I'll say things like, I worry that artificial nutrition or hydration will not help you feel better or live longer. And it could also make you more uncomfortable. You know, if people are still requesting and feel very strongly about, hey, I really want to give it a try, despite everything you said to me, you can also consider a time limit trial on a case-by-case basis. And so it's a shared decision-making that if I am seeing signs that it's causing you more discomfort, then I'll stop it. Building rapport, and then also just guiding it as well with your medical, clinical expertise. And so when people are talking about palliative sedation, which can sometimes be a hot topic, as we define it, it's really the use of medications like a midazolam infusion or barbiturates to induce decreased or absent awareness in order to relieve otherwise refractory suffering at the end of life. And the important takeaway to keep in mind with palliative sedation that it really should be a measure of last resort and be quite uncommon. And it's different from physician-assisted death or suicide or euthanasia, because the cause of death is the underlying disease and not the intervention itself. And so when it comes again, you know, in summary, educating families and loved ones during this time is so important, whether it comes with weakness and fatigue that comes, people's loss of ability to swallow, secretions, when it comes to delirium, confusion, and agitation during this time, changes in breathing, really the commonality of decreased oral intake and just anorexia, not being able to have sort of normal blood perfusion, really decreased perfusion, cool skin, oliguria or anuria, a loss of sphincter control and incontinence, and then also a decreased ability to communicate in time and talk to their loved ones. We though, often say that people at the end of life, sort of the last sense to go is their hearing. And so we encourage them to touch their loved ones, even if they're not able to communicate and are sleeping more often, and to just share whatever you need to share and say to them, because we do think the hearing is the last sense to go. So in summary, it is important thinking about the quality of care at the end of life that we provide. Symptom assessment and communication with patients and their families are key to guide our management. And thank you.